three different categories of psychotherapy we're going to be looking at here. Insight therapies. Insight therapies are talk therapies. They are our more traditional talk therapies that, of course, Freud started. Okay? There are many different kinds of them, but they have one thing in common, and that is the goal of the client and the therapist to gain insight. Thus, they are called insight therapies. Behavioral therapies. Okay, these have the goal of changing maladaptive behavior through the use of classical conditioning, operant conditioning, and also, can you remember the third one? That's observational learning. Yeah. And then we have biomedical therapies. This includes things like drug therapy. It includes shock treatments. We'll look at these in more detail later. So, beginning here with insight therapies. Okay. Psychoanalysis is one kind of insight therapy, and it's the one that Freud began. So, the main goal here with psychoanalysis is to explore the unconscious. So the therapist is seeking unconscious conflicts, unconscious issues, unconscious influences. That is what they are looking for, ultimately. All right, there are a lot of more modern psychodynamic therapies. Okay, and probably the most popular one is called client-centered. Sometimes that is called person-centered. Both terms are used. Okay, and the goal here for the therapist is to provide a supportive emotional climate with really genuine, unconditional positive regard and empathy for the client. To keep interpretation down to a minimum, very different than psychoanalysis. Also to keep guidance down to a minimum, because the idea here is once that the client is in an environment like this, they will know what the best advice for them is, even better than the therapist. Okay? It's a really interesting one to study because creating that environment can be trickier than what you think. And remember that word genuine. It really has to be genuine to work. Okay? And the effectiveness, so when we say, does it work, right? The effectiveness, when measured through psychological test scores before and after, with the therapist doing the ratings, with the clients doing the ratings, with family members doing the ratings, etc. It has shown that insight therapies are significantly higher recovery than no therapy at all. All right. Now, behavioral therapies. Remember, the goal of behavioral therapies was different than the insight one. That's kind of more of a cognitive goal, right? Now we have a definite behavioral goal of changing maladaptive behaviors, making them more adaptive. Okay? So we're going to look at a few different types here, and we're going to start with a very popular one, systematic desensitization. And oftentimes in the classroom, I will ask students, what is the very first step of systematic desensitization? If you were the therapist, what is the first thing that you would do? And oftentimes, students will say, build a hierarchy if they've had any background in this whatsoever. Okay? Actually, that's not the very first thing you're going to do. The very first thing is very important, and that is relaxation training. Relaxation training. Okay? So there are many different types of relaxation training that you can teach a client. One of the most commonly used one is breathing exercises. And this is especially effective if it is paired with biofeedback. So in other words, if the client even thinks about their fear object, maybe they're afraid of flying, and they're thinking about their fear object, right? If somebody really has a disorder, the phobic disorder, fear of flying. This is really extreme. Just thinking about this will bring up all the arousal symptoms like blood pressure and heartbeat, trembling, sweating, so on and so forth. Okay? So to have the biofeedback and to have them think about this, but then have them engage in what you're teaching them with these breathing exercises, we'll say for this example. Okay? What happens over time is they can see with the biofeedback that it's really working. Their heart rate is coming down, right? Their blood pressure, so on, all of these different ratings are coming down. And when they can do that, just thinking about this, then we are ready to begin the next step of systematic desensitization, and that is to make this hierarchy. So starting the hierarchy, it's going to be a hierarchy of fear, and we're going to work our way up to the thing that the client is the most afraid of. Okay? So we've already seen that the very first level is going to be just thinking about flying, right? Because that brings about this arousal. And then we're going to move each step up. So the next one might be getting into a flight simulator. Just getting into it, not even starting it, just getting into it because it feels and looks like you're getting into an airplane. Okay? And then the next step might be starting the flight simulator. And then the third step, might be actually driving to an airport. And the next part might be actually going to a gate or buying a ticket. So you can see how this goes. You're going to build this fear hierarchy starting at the very bottom and going to the most fearful of all, which would be taking a real flight. Okay? And the idea here is that we want to use classical conditioning to work on each step of that and associate it with relaxation instead of all of that unpleasant arousal. Okay, so you'd start with the first step, having them think about flying, but using their breathing until they can think about it without, and you can see with biofeedback, without this arousal. Then you move to the next step, maybe a flight simulator, and you work with that again until they are comfortable, they're relaxed, they can handle it. And then you move up and up until you're finally taking flights with them. Most often, at least on the first flight, the therapist will go with them. Okay. Now, this next one is aversion therapy. Okay. This one is used to eliminate undesirable behavior by classically conditioning it, pairing it with something very negative like maybe a shock or nausea. Okay. Social skills training is also a behavioral therapy because you're trying to replace maladaptive social skills with more adaptive ones. And sometimes we have the feeling that people are either born with this or they're not. And to some degree that's true, but just to some degree, because what has been found is that we can work with clients and teach them social skills to the point where it really makes a difference in their life. Their life is better. Okay? Their quality of life is significantly improved. Okay? And oftentimes that entails the therapist kind of improvising interpersonal skills, using modeling so they can do it first, respond to a particular situation in role play in front of the client, and then have the client do it, have the client practice it inside and outside of therapy. Okay. Then we have cognitive behavioral treatment. And this is a mixture of working on cognitions and on behavior. So changing not just the behavior through these different techniques, but also changing negative thoughts that may be associated. Cognitive behavioral treatment. Now, how effective are these? again, as measured through psychological test scores, so ratings before and after by the therapist, by the client, by family members, etc. Significantly higher recovery than no therapy at all or a placebo, same thing. Okay, now one exception there, that is when we look at aversion therapy. Okay, if you use aversion therapy to try to get rid of something you really want to get rid of that you don't want in your self-concept, let's say smoking, okay, it is better than nothing to use aversion therapy. Maybe take a drug that will make you feel ill and nauseous, maybe even vomit if you have a cigarette. And that might be helpful for a while, especially at the beginning of this process of quitting smoking. But if you try to use it to change something that is naturally ingrained in someone, hey, not very effective at all. So as an example, if you love ice cream, I could use aversion therapy and I could teach you to dislike ice cream, but it probably only lasts about a couple of weeks if you truly like ice cream. All right. Moving right along to biomedical therapies. We have some interesting ones here. First off, we've got psychopharmaceutical therapy. All right. And you're probably familiar with some of these medications. You don't need to memorize these names. But for each category, I'm going to give you some names, some example names. You don't need to memorize these examples. But psychopharmaceutical therapy includes anti-anxiety medications. Some most common ones are Valium and Xanax. Antipsychotic medications, these are used now instead of for treating anxiety, more for treating hallucinations and or delusions, sometimes for hyperactivity, oftentimes with schizophrenia, oftentimes with really severe mood disorders. Okay, some of the most typical ones are Thorazine and Haldol. They work by reducing dopamine activity. There are some newer ones now, though, that are called atypical medications, and with less side effects, but with higher diabetes and cardiovascular kind of problems that might be associated, so different kind of side effects. And then we've got antidepressants, and just like this sounds, this is used to treat depression, serious depression. And these elevate the mood, and they do so by increasing serotonin levels by slowing down that uptake process. Remember that kind of vacuuming process outside of the neuron. So some of the most common ones there are Prozac, Paxil's another, Zoloft would be another. Right? And then we've got mood stabilizers, and as these imply, they control moods. They're usually used with bipolar. An example that most popular would be lithium. Okay? So now, that is used as a stabilizing, mood stabilizer. So usually when someone is actually in an episode, so say they have bipolar disorder and they're experiencing a depressive or a manic episode, they're going to need 2 or 3 kinds of medications to get them out of the current episode. And then usually one just to stabilize the mood and to reduce the frequency of these kinds of phases. How effective are these different psychopharmaceutical therapies? I'll tell you something, this is really hard to determine. And the reason for that is because pharmaceutical companies control the research. So we could get better answers, right, if that were not the case. And these companies have a motive, right? They've got a motive of profit. Okay? So very difficult to determine. What we do know is that with schizophrenia and with bipolar in particular, There is no controversy here. They are very effective and very needed for someone to lead a much better life. So there are people who have very severe bipolar disorder, very severe schizophrenia, but function as high-paid attorneys and so on because of the fact that the medication makes this possible for them. It reduces the number of episodes. If it's a severe episode, they're going to need to be hospitalized. They're not going to be able to work during that period, but it really reduces when that happens and the severity sometimes of the episode. So another kind of biomedical therapy is what is sometimes referred to as ECT, electroconvulsive therapy. Okay? Also known as ECT. And what is done here is that seizures are actually produced, okay? Seizures, convulsions of the body through electrical shock. Okay? In the 40s and 50s, this was used a lot more commonly and very overused and really got a bad name. In the 60s and 70s, this was really cracked down on, and since then, it's only used when it's really needed. Most of the time, this is not popular belief, but it is a fact. Most of the time, clients really want this. So, depression is where this is the most helpful. Very severe depression. Some clients have found that when they go into a severe depression, nothing will bring them out except for ECT. And they request it and they sign a power of attorney ahead of time, and they want this to be done. They want to return to their normal lives. Okay? And they know that severe depression can be a threat to their own life as far as thoughts of suicide. Okay? And when this is used when it's not the client's choice would be in an institution if somebody is a danger to other people or to themselves. That is the only time that this would be used against a client's will, okay, is if they are posing a danger to other people or to themselves. And everything else has been tried and nothing else works. So as a last resort, they will use this, okay. Now, research shows that there are some short-term memory problems that are caused by ECT. Not long-term ones, but short-term ones. Things like attention deficits and other cognitive deficits. But they quickly clear up after treatment. Okay? Research shows no long-term effects. It's controversial, not because of that, but because of the fact that the reduction in depression, what causes that with ECT, is still a mystery. So it doesn't appear to involve neurochemicals. And because it's not quite understood, sometimes people feel it should not be used. And again, most of the time when it is used, though, it is by the client's request. All right, one more kind of biomedical therapy we're going to look at here, and that is psychosurgery. Psychosurgery, again, was very common in the 40s and 50s, far too common, used when it shouldn't have been used, misused, in other words. And this is mostly a frontal lobotomy. Frontal lobotomy, when that is performed, what happens is small holes are drilled in the frontal cortex, and then the connections are cut between the frontal cortex and other areas of the brain. Okay? And this reduces violent behavior in about 1/3 of patients. So it reduces violent behavior. It can have some irreversible side effects, such as epilepsy. That's rare, but it can happen. And sometimes side effects can be fatal. In other words, it might be an epileptic seizure that is so severe that the client dies. So obviously this is never going to be used except as a last resort to reduce violent behavior. And then only because they've tried everything else and nothing else works, and other patients are at risk because of this particular patient.